Many consider history to be dull and dreary, an exercise in memorizing a series of dates linked to events and long-dead people, without any general principle linking them together. And researchers in particular are notorious for having little interest in the history of their discipline. And this is not surprising, because science deals with discovering facts, such as quantifying the degree of sternomastoid activity in weaning failure patients. And to do this, we distance ourselves from the world. We are looking at the problem from the outside. We are external onlookers. But we can further increase our understanding of a scientific topic by also looking at its historical evolution. To maximize understanding from studying the history of science, we need a different mental set. We need to empathize with the historical characters we are reading about. To place ourselves in their shoes, to empathize with the challenges they faced, how to overcome them or failed to overcome them. In contrast with the mindset used for science, we need to look at the problem from the inside, to be internal onlookers. We gain the greatest understanding by using both perspectives. To introduce a series of articles oriented on history in the American Journal of Critical Care Medicine, I wrote an editorial which contained a synopsis of 400 years of medical history, and I justified the focus by saying that history provides us with a scale and with a time constant for extrapolating into the future. From our perch in the present, we look back and we see how the complexities of today evolved from relatively simple roots. A panoramic perspective of the past enables us to understand change and its significance. And this is the key factor. So say you visit the Acropolis in Athens, you can walk through the extensive ruins. But if you want to grasp the splendor of the overall construction, what Pericles and Phidias, his architect, achieved, it's better to be able to combine it with a panoramic perspective. And viewed from the sky, our wonder of the Acropolis is even greater, because this gives us a panoramic perspective on the past and also a greater appreciation of our subspecialty. And that is the reason why that though history is about the past, it's our key to the true understanding of the present, which is simply the edge of the past. So now I start to focus on the history of mechanical ventilation per se. And the concept of artificial ventilation dates back to prehistoric times. Here we see Elisha restoring life to the son of the Shunammite as described in the Book of Kings. And as described in the Book of Kings, it says, "And he went up and lay upon the child, and put his mouth upon his mouth. And he stretched himself upon the child, and the flesh of the child waxed warm. And the child sneezed 7 times, and the child opened his eyes." All medical disciplines would like to be able to link their birth to this book, the most venerated in medical history, yet few are able, but intensivists are able. And the book is the Humana Corporis Fabrica, published by Andreas Vesalius in Padua in 1543. And in the center of the frontispiece, we see Vesalius looking out at us. Vesalius is inviting us to look inside the open body, which henceforth will be the source of truth. Vesalius was from Flanders, present-day Belgium, and he worked at the University of Padua in the Venetian Republic. And note the year of publication, 1543. And that's the exact same year that Copernicus published his revolutionary book saying that the Earth revolved around the Sun. But the coincidence is even stronger because, like Vesalius, Copernicus also trained as a physician, and he also trained in Padua. Padua was also where Galileo worked, and it was where William Harvey trained. And so if any one city can be regarded as the birthplace of the scientific revolution, it is Padua. And in the top left corner of the Fabrica, you can see the letter Q. And inside the Q, in the inner details, shows cherubs doing an experiment on a pig. And Vesalius writes, but that life in a manner of speaking be restored to the animal, an opening must be attempted in the trunk of the trachea, into which a reed or cane be put. You will then blow into this reed so that the lung may rise again and the animal take in air. And by rhythmically inflating the lungs, you restore life to the animal. And Vesalius writes, quo mihi gratius in anatome nullum compere. So from this it's clear that Vesalius recognized that his discovery was monumental. So why was his description so modest? Was he afraid of incurring the wrath of the church? As was to happen his fellow Paduan Galileo 90 years later. The first scientific journal was the Philosophical Transactions of the Royal Society, founded in 1665. And 2 years later, Robert Hooke of Hooke's Law reported a very similar experiment to that described by Vesalius. And the title of his article was an account of an experiment made by Mr. Hooke of preserving animals alive by blowing through their lungs with bellows. And Hooke begins his article by writing, I caused at the last meeting the same experiment to be shown in the presence of this noble company. In those days, simply writing up a report and publishing it did not constitute sufficient testimony. Instead, the researcher was required to do the experiment in the presence of the assembled members of a society. Hooke continues, the dog being kept alive by reciprocal blowing up of his lungs with bellows. And Hooke's published account of the experiment is the usual dispassionate, deadpan presentation that we have come to expect as normal for a scientific journal. But he also wrote a how it really happened description in a letter to his friend Robert Boyle of Boyle's Law. And in this he wrote, the other experiment which I shall hardly, I confess, make again, because it was cruel, was with a dog which by means of a pair of bellows, wherewith I filled his lungs and suffered them to empty again. I was able to preserve alive as long as I could desire, after I had wholly opened the thorax and cut off all the ribs and opened the belly. But I shall hardly be induced to make any further trials of this kind because of the torture of the creature. Hooke left out these grisly details from the report he published in the Philosophical Transactions. So to recap, we begin our story with Vesalius in 1543. So to place medical events in perspective, I also indicate what was happening in the non-scientific world at the same time. Vesalius comes a little after Leonardo da Vinci and before Shakespeare. Events related to mechanical ventilation are above the timeline, and non-medical events are below the timeline. And the alternate white and blue shadings represent 50-year periods. So we next move to Paris in the 18th century with the first reports of attempts to resuscitate apparently dead people. In 1740, the French Academy of Sciences strongly advised the use of mouth-to-mouth respiration for resuscitating the apparently drowned. And in the late 18th century, there was great interest in the resuscitation of victims of near drowning. And societies to help with this problem were founded in several European cities. Here we see equipment from the 1806 annual report of England's Royal Humane Society. And on the left we see 3 different types of bellows for inflating the lungs, and flexible tubes for injecting stimulating vapors or smoke into the lungs. A curved pipe was passed down the throat beyond the glottis to inflate the lungs, and a bellows that is already connected to a oropharyngeal cannula and ready for use. John Hunter proposed the use of dephlogisticated air or oxygen, which had recently been discovered by John Priestley and Lavoisier. Hunter wrote that oxygen is easily procured and may be preserved in bottles or bladders. And here we see the famous painting of Lavoisier and his wife by David. Lavoisier's wife leans on his shoulder like an inspirational muse. But this was far from the role she actually occupied. Marie Anne was an indispensable research assistant, and she studied drawing with David in order to illustrate experiments. Here we can see her drawing portfolio resting on a chair. The experimental apparatus receives great prominence. We see a gasometer, a barometer, and a pneumatic trough, and a glass flask with a stopcock. So we remain in France in 1827 for the work of Libois d'Altol. And at that time, the police were using bellows extensively for resuscitating victims of near drowning. And they told it animal experiments and found that overzealous inflation with a bellows caused fatal pneumothorax. He concluded that the use of bellows ventilation by the police was killing people, not saving lives. And based on his report, the French Academy of Sciences condemned the use of bellows ventilation. And England's Royal Humane Society followed suit. And so early in its use, positive pressure ventilation was banned from medical practice, and it was not tried again for another 120 years. So now we move to negative pressure ventilation with the Jones tank respirator. In 1864, Alfred Jones of Kentucky patented the first body tank respirator in America. And in his patent application, Jones said that the respirator would cure asthma, bronchitis, rheumatism, paralysis, and many other diseases. In 1876, Follet presented a tank respirator to the French Academy of Medicine. He included a bar on the sternum to measure tidal volume. But this tank was used only for resuscitating the apparently drowned, and it met with little success. A few individuals ignored the injunction of the French Academy of Science and the Royal Humane Society, and they persisted with positive pressure ventilation. In 1893, George Fell in Buffalo reintroduced the use of bellows for resuscitation. And O'Dwyer in New York designed a cannula for intubation. And Rudolph Matas, professor of surgery at Tulane in New Orleans, successfully used the O'Dwyer Fell apparatus for a thoracotomy in 1899, but it never caught on. So we next moved to Germany in 1904, where Sauerbruch developed a pneumatic chamber to overcome the pneumothorax problem. This was the same problem that Vesalius had described 350 years earlier, that as soon as the surgeon opens the chest, the lungs collapse and cease to function. And Sauerbruch's pneumatic chamber generated negative pressure around the body from the head down, and the head and the mouth stayed outside at atmospheric pressure. When the surgeon opened the chest, the lungs would then remain inflated. So negative pressure changes rapidly gained popularity throughout Europe and the United States. Up to 1940, Sauerbruch was widely regarded as the greatest surgeon in the world. He later served on the Reich Research Council, which approved grants for the Engl twin experiments in Auschwitz. Clear evidence that history, even medical history, does not necessarily represent a progressively upward evolution. Moving across the Atlantic, in 1909, Willy Mayer, thoracic surgeon at the German hospital in Brooklyn, built a large Sauerbruch chamber that could fit 17 persons. The patient's head protruded through an opening, and the anesthesiologist sat in a small outer chamber. The introduction of the Sauerbruch chamber, which emphasized negative pressure ventilation, probably delayed progress in mechanical ventilation by 40 years. In 1928, Philip Drinker described another ardent lung. Here we see Drinker ventilating a curized cat with tidal volume being recorded on a Crow kymograph. The following year, Drinker described its use in ventilating an 8-year-old girl with polio. In 1931, Jack Emerson simplified the tank respirator, and the Emerson arm lung was the first respirator to be successfully used on a widespread basis. The body was entirely enclosed in a cylindrical metal tank. The patient's head protruded through a close-fitting rubber collar, and the Emerson tank respirator was the mainstay for polio until the 1950s. And now we come to the last entry on our timeline. We arrive in Copenhagen in 1952 for the final chapter in our story. In September 1951, the University of Copenhagen hosted an international poliomyelitis conference. Attendees included Jonas Salk and Albert Sabin, who had later discovered the polio vaccine, and doctors and scientists doing polio research all over the world attended the conference. Inevitably, some researchers were silent carriers of the virus, and these researchers were almost certainly the source of the catastrophic epidemic that engulfed Copenhagen the following year. Polio cases had been registered in Copenhagen since 1905, and there had been repeated small epidemics gradually increasing in size through the 1930s and 1940s. In 1952, the attack rate was 2.38 per 1,000 inhabitants, meaning that there were 3,000 cases in metropolitan Copenhagen, making it one of the largest epidemics ever in the world. Even more disturbing were the proportion of paralytic cases in 1952, which far exceeded all previous experience. Thus, the need for negative pressure ventilation markedly increased. There were 10 patients per year in the 1940s, whereas in 1952, they were having 10 patients every week. Here we see the number of admissions in a week to Plegdam's Hospital between July and December of 1952. The key event in the story I am about to relate took place on August the 27th, 1952. That week, 335 patients had been admitted. That is about 50 new cases every day. Smaller epidemics were happening around the world. In Los Angeles County Hospital, we see a ward full of ardent lungs during the polio epidemic. But in Copenhagen, they had only one ardent lung and 6 cuirass respirators. This was their single ardent lung in Copenhagen. And in the first 3 weeks of the epidemic, 31 patients had undergone negative pressure ventilation, but 90% had died. Henry Lassen was the chief physician and epidemiologist at Flegsdam Hospital. And on the wall behind him, we can see the upward slope of the new cases occurring in the epidemic. Lassen knew that he needed to improvise. And he invited Lundsgaard, a world-renowned physiologist who had been trained by 3 Nobel Prize laureates. But Lundsgaard had no solution to the problem. Lassen was advised to consult Bjorn Ibsen, a freelance anaesthetist. Lassen was skeptical, reflecting the prejudice of the time. Anaesthetists were looked on as technicians, not proper physicians. Their acknowledged expertise was restricted to the operating room. A meeting was held on Monday, August the 25th, at Flegsdam Hospital between Lassen, Ibsen, Paul Astrup of blood gas fame, and other staff members. Lassen discussed the terminal course of polio, that patients typically had fever, cyanosis, and hypertension, all of which were thought to be caused by viral encephalitis of the brainstem. Astrup noted that the patients had a high plasma total CO2 content, which was attributed to a primary metabolic alkalosis because the pH was not measured. Ibsen proposed a radically different pathophysiology. He believed that the terminal signs resulted from hypoventilation and that the high total CO2 content reflected respiratory acidosis. This was heresy. It was argued, how could a patient hypoventilate if he or she was already in a tank respirator? And it was well known by experts that the terminal manifestations were caused by viral infection of the brain. Ibsen followed up his heresy by also recommending a radical new treatment: tracheostomy and bag ventilation by hand. It's not easy to recapture the scene that Monday morning. We have a 37-year-old freelance anaesthetist who has no real understanding of polio. And on the other side is a physician who is 15 years older, who is the leading authority on polio, and he is the chief physician, meaning that he has ultimate say on the management of every patient in the hospital. And Ibsen is telling Lassen that his understanding of the terminal stages of polio is wrong. Lassen was not convinced by Ibsen's arguments, but to his eternal credit, he gave Ibsen the benefit of the doubt. Ibsen was allowed to try tracheostomy and bag ventilation on one patient. On Wednesday, August the 27th, Lassen picked 12-year-old Vivi Ebert, who was gasping for breath and drowning in her own secretions. In his book, On the Rise and Fall of Medicine, which I strongly recommend, James Lafano writes, "There followed one of the most dramatic and in its consequences profoundly influential moments in the history of medicine. An ENT surgeon performed a tracheostomy. Ibsen then tried to inflate Vivi's lungs. He found it difficult because of the increased airway resistance, partly from secretions and partly from bronchospasm. Within minutes, Vivi was dying. The physicians who had assembled to see the new treatment began to drift away discreetly so as to avoid the embarrassment, saying that they needed to take care of the many new patients being admitted. Vivi was getting very agitated. At 1,302 hours, her CO2 was 7.5%. At 1,317, Ibsen gave her 100 milligrams of pentothal. And here we can see in Ibsen's own handwriting, he describes how Vivi's weak respiratory efforts immediately ceased. Now at last Ibsen was able to ventilate her properly. Her cyanosis disappeared without any administration of oxygen, and her blood pressure returned to normal. Vivi's CO2 fell from 7.5% at 1,302 to 3.5% at 1,335. And when the physicians returned, Ibsen transferred Vivi back in to the ardent lung. Now her skin became clammy, her blood pressure rose because of CO2 accumulation. As soon as Ibsen began to bag Vivi again, her condition improved. Astrup came back and he took a blood sample from Vivi. Bagging caused a decrease in the plasma's total CO2 content. Astrup immediately called on Radiometer, which is also in Copenhagen, to get one of their newly developed pH electrodes. And next day, he used the electrode and found acidosis, not a primary alkalosis, was occurring in the terminal stages of polio. So Ibsen's heretical ideas were proven true. Lassen energetically implemented the new therapy. He appealed to medical students for help. And on Ward 19 was an amazing sight. There were 70 beds in 2 straight lines, and a child in each bed was being bagged by a medical student who worked a 6-hour shift. About 1,500 medical students and dental students bagged for a total of 165,000 hours. And the mortality decreased from 90% to 25%. Vivi survived, and here are notes from a subsequent admission, and she had lived for another 29 years. Like many great incidents in medicine and science, outsiders see the incident as of far greater importance than do the key players. I exchanged several letters with Bjorn Ibsen, trying to get him to write an essay for the How It Really Happened series in the American Journal of Respiratory and Critical Care Medicine when I served as editor. And here is his reply to me. He says, "Dear Dr. Tobin, my reason for refusing to write an essay is that I have always, at that time and later on, felt that the whole thing was so simple and evident that I was not impressed myself. I was only surprised that they could not see what was wrong. CO2 accumulation under nasal oxygen and under ventilation, something which was already known by many at the time. How can I comment on that? Bjorn Ibsen." Well, Dr. Ibsen may be too humble, and he may think that the incident is not worthy of comment. But I think otherwise. I believe that intensive care was born on Wednesday, August the 27th, 1952 in Blegstad Hospital, when 12-year-old Vivi was trained and bagged by Dr. Ibsen. And then medical students showed that the use of an artificial airway and positive pressure ventilation could decrease mortality from 90% to 25%. So stories like that of Dr. Ibsen and other pioneers in mechanical ventilation, they serve as our muse, providing us with inspiration as we try to invent better ways to ventilate patients. Thank you.